that we begin with history taking and treatment planning and move into preparation. But once we hit the gas and we're into the phase of the work where we're regularly doing processing, right, then we trust the brain, and the brain takes us places we don't expect to be going, and we bring in feeder memories. And we may need to go back and do more preparation work in any session, right? We may need to go back and do some ego state work, or do some emotional regulation work, or some relational work, and then we go back into processing.
Today we're talking with authors of the book Every Memory Deserves Respect, Michael Baldwin and Dr. Debbie Korn. Debbie and Michael will explain from a client's perspective and from an EMDR expert's perspective what makes EMDR so powerful when treating complex trauma. We'll talk about why EMDR is a nonlinear process and why so many therapists are not asking their clients about history of trauma. Debbie will describe specific strategies to work with clients who have complex trauma, rigid defenses, and dissociation. Here is the conversation with Michael Baldwin and Dr. Debbie Korn. So Dr. Debbie Korn and Michael Baldwin, I want to welcome you back to the Art and Science of EMDR, and thank you for joining the EMDR learning community.
Thank you for having us.
Great to be here. Thank you, Rodham.
Yeah, so we're talking again about this book, Every Memory Deserves Respect, which we talked about in the past, but I want today to specifically focus about treatment of complex trauma. And so before we get to talking about the treatment, I want to ask about just complex trauma. What makes trauma complex? Isn't trauma by definition complex?
It's a great question to start with. Well, I think, when we think about what distinguishes complex trauma from other types of trauma, complex trauma is repetitive, prolonged, pervasive, often ongoing. It's also interpersonal trauma, right? It involves attachment ruptures, involves relational betrayal. It often occurs within time periods where there's incredible vulnerability. So in childhood, often starting in early childhood, it often occurs in families or closed systems, not necessarily families, but closed systems where there's a lot of coercion, where there's a lot at stake, where escape is difficult, where there's dependency issues, where one's livelihood might be at stake, one's survival might be at stake. It's often intergenerational. And it also complex trauma involves both commission or acts of commission and acts of omission. So by commission, we're talking about things that happen to you, more of the big T traumas that we think about when we think about PTSD, sexual, physical, emotional abuse. And it also involves omission, which is neglect and deprivation. So when you put that all together, it's multi-layered, multifaceted exposure to trauma.
Right. Michael, so I want to ask you now, you had complex trauma. You had in the past. Is that fair to say that you had complex trauma? And can you say with confidence that your trauma belongs in the past and you no longer have trauma?
First question, did I and can I say it with confidence? Yes, I can. But it took me a while to discover that. I had seen 8 therapists before I engaged with Dr. Jeffrey Magnavita. And just to be clear, for your audience, Rodham, Debbie was not my therapist, she was my co-author.
Right.
And as far as in the past, I think it's a process of discovering it, understanding the nature of it, and then putting it into perspective from an adult point of view. So then it's allowed to, what happened is a constant, but your interpretation and perspective of it is through an adult's lens versus a child's.
Yeah, and I think this message is really, really important both for, the general audience or the general public, the people who might have trauma, and for therapists, because I think about myself before I was trained in EMDR. My belief was that once you have trauma, you have trauma. You have it for the rest of your life. It's not something that can be healed. It's something that maybe can be managed. Um, but the interesting thing, Michael, that Debbie writes in the book is that when she first met you, you told her that you had a therapist before Dr. Magnavita, and nobody asked you about trauma. Why is that? Why do you think it is that nobody asked about trauma?
So that was over about a 22-year period. And I don't know why. I would say the early end of that spectrum might have been just a general state of the therapeutic community. But not only did they not, it was never mentioned. Literally the word was never mentioned.
Mhm.
So, and I had exposure to talk therapy, to CBT therapy, to short-term intensive psychodynamic therapy, lots of them. It never came up. I did not hear the word, know anything about trauma or EMDR until I engaged with Dr. Magnavita.
Yeah, so we had some interesting discussions in our community about why why some therapists don't even ask about trauma. And some people said that maybe because you worked in marketing and you're wearing nice clothes and you just don't look like someone who has trauma, whatever that means. Some people said that some therapists are just focusing on the symptoms, which sometimes, or a lot of times, trauma manifests itself as anxiety or depression. And some therapists don't feel comfortable asking these tough questions about trauma. And a lot of people actually said that in their training, in their graduate school, it blows my mind, but that they didn't learn about trauma, or there was like very limited amount of information about trauma. So
Rodham, also, I should add that I think I felt I was like a lot of people, maybe even the whole general lay public population, because my understanding of that word would have been um, combat, natural disaster, or maybe being held up at gunpoint. That was my understanding of that word. Just so you know, that would have been my point of reference.
yeah, so people came back from Vietnam, they have trauma, but not people who were maybe abused, or even like what Debbie mentioned, the act of act of omission, that was not considered trauma.
Now,
Yeah.
most therapists don't know how to ask about neglect or deprivation, and it's not on the survivor's radar because it's hard to name something that didn't happen, that was missing, right? So I think it's really important to ask questions in your initial assessment about loneliness, about feeling profoundly and utterly alone, for having, experiences of yearning or needs unmet, wishing that someone would take care of you or see you or hear you. I use language like that to try to start looking at those experiences of, of being lost.
And I think for a lot of us, right, as therapists, we want to find solutions, and some therapists just didn't know how to navigate some of that information, right? Like, if I don't know how to treat this, how am I going to dig deep on this? Because we didn't think that you can heal people, right? Like, so let's just focus on the symptoms reduction, right? But now and this is where your book is so beautiful, and being able to relay that information that you can heal, that there is that power of healing within EMDR to help people with trauma.
Mm-hmm.
Yeah.
Major shift.
I wanted to, one of the interesting things that I personally found in the book is that you write about how EMDR treatment is not linear. And I wanted to ask, Michael, did the treatment with Dr. Magnavita, did that feel linear? Because, we're being taught that there's 8 phases, and some people are really, some EMDR therapists in their, especially in the beginning phases of their EMDR career after basic training, are struggling with that because we're being taught a linear model, but treatment itself is not always linear. So what has been your experience with Dr. Magnavita?
So I will tell you that when I walked in his door, I think it was obvious to him the level of distress that I was in, number one, and back to this whole discussion of complex trauma. And in my case, that was very much having to do with neglect, or as he called it, willful neglect. And I had no idea about any of this whatsoever, starting pre-verbal, just the extent and of it, and how long it lasted, and the effect it had on me. And I think one of the words Debbie used was longing is a really important word, because there's so much pain associated with that notion of longing. As an adult, you get back in touch with how that vacuum, that empty space where you wish it had been filled. And so in terms of linear or nonlinear, I would say it was very nonlinear, and it was almost like maybe chipping away at something and then going maybe elsewhere because where the memory path leads, but then coming back to the same place, chipping away more, and you get deeper. And in a couple of major cases, traumatic episodes, that was the process through which we eventually got to the source for me of things that had been plaguing me for 40 years.
Yeah. Yeah, thank you for sharing that. Debbie, I'm wondering what your thoughts are as someone who's been, not only practicing EMDR, but teaching it and providing consultations. How do you see it? We have 8 phases, so there is some progress on a line, if you will, linearly, but also especially when it comes to complex trauma, at least the way I see it, I don't perceive it as linear, and I'm wondering what your thoughts are on that.
No, I don't perceive it as linear either. I would think of it much more as circular or a spiral, where we return to the top of the spiral again and again, and we go again until we get to a new place, and then we go back and we ride the spiral again. Or I think of it, I love to dance. I think of it as a boogie woogie 2-step, where you go forward 2 steps and you go back 2 steps and you go to the side, and it doesn't feel linear to me. And we begin with it. We begin with history taking and treatment planning and move into preparation. But once we hit the gas and we're into the phase of the work where we're regularly doing processing, right, then we trust the brain, and the brain takes us places we don't expect to be going, and we bring in feeder memories. And we may need to go back and do more preparation work in any session, right? We may need to go back and do some ego state work, or do some emotional regulation work, or some relational work, and then we go back into processing. And we also kind of jump around in terms of, we may start by targeting past experiences, but then, as quickly as we can, we want to go and see how are they doing with their present triggers, and can we begin to put a foot into the future and help people begin to generalize the shift that they're experiencing in session into taking new initiatives and trying new things. So, I think it's not even linear in terms of past, present, future. Sometimes I start with future with people. Sometimes I start with present, just depending on what the case conceptualization is, what's needed, what the client is ready for. So I think it's very, very helpful to have the linear phases in mind, but I think we move, in multiple directions within those phases.
Yeah, so there's the linear structure, kind of like general guidelines, but when it comes to complex trauma, it's not necessarily, I would say most cases it's not moving
No.
linearly. And I think that, the example you gave, that we go back to ego state or to grounding. So, and sometimes when it comes to complex trauma, we're kind of like almost doing phase 4 and phase 2 at the same time, right? We're titrating
Yeah.
the
Well, we're bringing in the stabilization skills or the strategies through interweaves. And in fact, I would say you don't need to go back to preparation. Stay in processing, stay in the desensitization phase, but bring everything you know from the preparation phase to bear so you can keep going forward. You don't need to go backward necessarily.
Yeah. What other strategies do you use when it comes to complex trauma? Again, when it comes to, working with clients with maybe rigid defenses or high levels of dissociation, what do we do differently with these clients?
Yeah, well, I think that's where the real complexity is. And I think that's where the real skill is required in working with complex trauma folks, because you need to be able to track moment to moment with complex trauma clients, because at any moment they can fall out of that window of tolerance. Suddenly they're in hyperarousal and they're getting flooded. And if you're not there to help them down regulate, they're going to hit the brakes, or they're going to, they're out of their window of tolerance and they're shutting down, they're going into a collapse, they're starting to dissociate. And if you're not there to just coach them and help them, to keep that train moving down the tracks, you're going to lose the client, or it's going to become a negative, even potentially harmful experience. So, first and foremost, you're tracking their regulation, their self-regulation, and you're inviting them to allow you in to help them regulate. And you're doing that in all different kinds of ways. You're doing that with your voice. You're doing that, by inviting them to breathe, inviting them to stand up, inviting them to lengthen their spine, inviting them to, to only let 2 drops of something come in rather than tackling something, or just, 2 seconds of something, titrating it or modulating it. So we're really involved moment to moment in keeping them within the window of tolerance. I think there are so many ways to use the self of the therapist moment to moment, to kind of everything from cheerleading the client to, letting the client know how proud you feel of them. Because again, complex trauma is an interpersonal trauma. It happened in the context of attachment, and so much of the healing is going to happen, or there's the potential for there to be so much healing in this interpersonal, intimate relationship that we call therapy. So yes, we're working on the memory. Yes, we're, trying to get that distress level down to 0. But as we're getting there, there are these opportunities to offer the client these corrective emotional experiences where they feel accompanied, they feel seen, they feel heard, they feel your pride in them, right? So, all of that will help keep them with the process, help them integrate new memories. Literally, you're establishing new memories as you go that get filtered in. I think you're going to hit defenses. Of course, you're going to hit defenses as the clients approach material that is daunting, that's, shame bound. And I think, again, the key is being able to track, where is the client at any moment? Are they accessing the memory, or have they left the room? Are they putting up walls? Are they disconnecting at a feeling level or a sensory level or a cognitive level? And can you invite them back? Can you ask that protective part to step back so they can come back to the memory and come back to their child's self? So really recognizing when the client has shifted into defense, it's not always obvious, right? Somebody who's processing and they're raging about something, and therapist thinks, oh, we got a lot of emotion here, we're accessing and processing, but it's not going anywhere. It's not, the memory's not transforming. That's probably a defense, right? They're a defense against feeling grief or a defense against feeling longing. And a good EMDR therapist is going to recognize that and offer a little interweave, bringing the client back, getting curious about what's underneath the anger or what else is there. And maybe the final thing I'll say is that with complex trauma, complex trauma involves disintegration, dissociation, right? Fragmentation. And we often need to help our clients to reflect and to paste pieces together. And so building that into the work as well, asking the client as they've come through processing something very difficult, to ask them, what was that like for you? And what did you learn from this? And what do you know now that you didn't know 5 minutes ago? Really helping them stretch it. What does it mean for you and the relationship that you're in now? So kind of building those bridges to present and future, and not assuming that the shift or the change is going to generalize on its own because of that. Because of all the walls that have existed for so long, information doesn't assimilate so fluidly.
Yeah, I think, Francine Shapiro famously said that therapists should stay out of the process. But I think when it comes to complex trauma, when I hear you saying what you just said, is that a lot of times we shouldn't stay out of the process. What did she say?
Stay out of the way.
Francine
used to say, stay out of the way.
Right. But
to the contrary. To the contrary, I think if the train is moving down the tracks and you're watching transformation happen and you're not seeing those rigid defenses and you're not seeing this, great, stay out of the way. Don't ever stay entirely out of the way. You want to be there with your voice and your love and your support and your cheerleading, and you're reminding the client this is old stuff and it's just a memory. But if you see the client heading for a cliff, right? They're about to shut down, they're about to plunge into shame, they're starting to look overwhelmed and pull out, get in there and help them regulate. Get in there with information. You don't want them to crash and have to pick them up from that place. So that's the importance of that moment-to-moment accompaniment. You know where you're trying to get to with the client, basically. And again, it may be a circuitous route, but if they're suddenly heading for a detour, you want to bring them back and get them back on the tracks.
What do you think will be something helpful for an EMDR therapist to become more aware and able to help clients that have complex PTSD?
Well, I think, for me, I've studied many other models that have helped me to be a better EMDR therapist. I've studied models that intensively focus on affect and intensively focus on attachment. So learning about how to track the attachment system, how to track affect, and how do you know when it's defensive affect or core affect has been really helpful. I've done a lot of work of, understanding dissociation and understanding ego state work and parts work, and that's been tremendously helpful. I've studied with, experts around body work. And so when somebody is stuck in a freeze in their body or somebody, is dysregulated at body level, I have a lot more ease in bringing in the kinds of interweaves that are helpful there. So I think continuing to learn beyond the EMDR community and, reading and attending workshop is really helpful. I think really thinking creatively about interweaves. I have a publication with Dini Laliotis that is in Barb Hensley's book, the EMDR Therapy Primer, that's all about these different interweave categories. And That's
the second edition, and now there's the third edition.
third edition, yeah. So, really understanding the purpose and the function of interweaves, so you know what you're looking for. You're not kind of just randomly throwing in your best attempt to get things moving, but you can really spot what's needed. What is this stuckness about, and what kind of help is needed? And then I would also say, be in consultation, videotape your work. All of my consultees videotape their work. We watch videotape every session. And that the growth for people in working with very complex cases, once they start videotaping, is tremendous.
Yeah. I so agree with that, Debbie, because when you're videotaping, your consultant can see exactly what's going on in session, as opposed to remembering or trying to remember what happened. And of course, your memory is selective, and it's 2 weeks later, and you had 80 other clients between. So it's all get mixed up in your head, as opposed to let's watch a video and accurately, like, let's stop here and tell you, oh, you could have done this, you could have, this was great, and you could have done used some other interventions.
Right. Yeah.
But I love that. It goes back to what we said as far as linear, right? Like linear versus nonlinear. Because Debbie, I appreciate you for saying what you said so much, because so many people leave the training thinking EMDR is only the 8 phases, but it's not until you actually learn more and integrate what you know about everything you said that then you can really become the best EMDR practitioner. Without all of that, I don't think you can you?
Well, and I also think that if EMDR is taught as a linear model, people expect their clients to kind of move smoothly from one place to the next, and don't realize, you're hanging out and reprocessing for a long time, or, there's an opportunity to jump and do something in the future and come back. And so what they're seeing in their clinical work is not going to match up with what they learned. So I think it's regretful that, when EMDR is taught as really a linear process.
Yeah, I want to open our conversation to Q&A, but before that, I have one more question for both of you. In the book, Debbie, you say that you can when clients come into your office, you can confidently say that, in the first session that, they, despite of being injured, they can recover, they can heal. And I was having a conversation with a colleague this past week about clients who have been sexually abused, complex sexual trauma. And my colleague was asking, can people really heal to the point that they can enjoy intimacy? Clients who, or individuals who had complex sexual trauma. I'm wondering what you think about it, Debbie, and then what Michael thinks about that.
Yeah. I think that fear around intimacy, or feeling inadequate around intimacy, or not being able to stay present and embodied in intimacy, it's all part of the old stuff. It all reflects trauma responses. So if we go to the root of it and we transform that trauma, we dump that trauma off, we move the trauma into the past, we allow the adult to kind of respond to their partner from an adult place rather than a child place, to look through their eyes and see their partner rather than seeing their perpetrator. There's absolutely no reason why people can't heal in terms of sexual trauma and can't, move to a place of deep intimacy, I think.
I would be, I used to tell Dr. Magvita that, there's I don't know how many people in your audience have seen Christmas Carol, where at the end of the movie, close the end, Scrooge runs over to the window, throws the shutters open, shouts down to the boy, says, boy, what a fine looking boy, what day is it? And he's hoping he hasn't missed Christmas. And the boy says, it's Christmas Day. He says, oh my God, I haven't missed it. It's still right. I'm not too late. I would tell him this over and over because I don't want to fling open the shutters and find out it's July 15th or something. It's October. I've completely and totally missed Christmas Day. Point being, if there's no hope in my life for intimacy, which I think intimacy and love and being in love, then I don't. To me, that's a gigantic disincentive proposition, disincentivizing phenomenon that would be really, really depressing to face. And in my case, part of the unfolding story that's really beyond the book and sort of coming out since my older brother has been seeing an EMDR therapist himself on his own journey now for almost a year. And we are finding out that a lot of the intimacy issues that our mother created, I think I was a more extreme case than my brother, but we both suffered as a result of that early childhood exposure, lack of boundaries, sexualization, in my case, sexual abuse that we talk about, because he was married, he's divorced, has two daughters, that we hope that is going to be a part of our life going forward, because that's such a gigantic part of life.
Yeah.
Right.
Okay.
And Debbie and I have actually talked about it, about how, when those things come up now for me, that's when you might find I might need to, circle, go see Dr. Magnavita again, because things come up, it's a whole nother area. Whereas Debbie said, where things can come up, not the old stuff, but, is this going to be okay? Am I going to be able to do this? Is this something, I'm a little scared, I'm a little nervous, etc.
Yeah. Okay, thank you. I want to switch our conversation. I want to invite the members of our community to turn their video on. And what we're going to do, we are going to record the rest of the conversation, but the rest of the conversation, the second half, will be only available to our community members. So people can ask you questions directly and maybe ask some things that are more personal or more about clients. So I want to thank you, Dr. Debbie Korn and Michael Baldwin, for being again on the show.
Thanks for having us.
Thank you.